lot of scientific sessions already going on. I'm the last batsman to finish. Still there is one more. Okay, so okay, still there are one more lecture is there. So maybe I will rush little bit, seeing the crowd's impatience, and the topic which was given to me is again very innovative topic. As this year's IDF theme is women and diabetes, and I think this Dr. Ashutosh's restless soul, I believe that he has all those topics put up so that we don't copy paste things. No, it is all you have to work up and put hard soul on it to see what thing he wants from us to be told and to be discussed in this meeting. So the topic is again CAD in women, particularly triglyceride, which was of late going flavor of cardiologists, but I could find few facts which will be very interesting to discuss over here. So the flow of presentation will be like this: introduction, then cardiometabolic disease pathophysiology, then triglyceride metabolism. I'll talk little bit of biochemistry here. Then high triglyceride and how it is translating to cardiovascular disease, and then recommendation and some very important points regarding menopause and cardiometabolic disease, which I have put, and then summary. Cardiovascular disease, as we all know, that is a leading cause of death, especially in women population in US as well as in Asia. Rather, we don't have our own data specifically to India, but then it is there very high prevalence, and it is estimated that 1 in every 2 women die of heart related disorders, which represents death, which is more death due to cancer, chronic lung condition and accident combined. So dyslipidemia is an important risk factor for the development of coronary heart disease. So cardiovascular disease is foremost cause of female death in developing world. The more than 50%, as I told, women die of CVD, including MI, heart failure and stroke. Cardiometabolic complications are multifactorial, as we all know that, and there is a wide spectrum of different factors, including changes in lifestyle, environment, diet, as told by ma'am just now, lifestyle, genetic and epigenetic factors are there. There are some biological and behavioral risk factor also associated to it, and although there are some isolated risk factor have a specific impact on health, they are more frequently clustered in an individual and they land up in this. There are the criteria to identify. See, the traditional risk factor in women, and then not in women, that is common for both, but then there are some emerging non-traditional risk factor for women, which I am going to illustrate here. Traditional being diabetes, smoking, obesity and overweight, physical inactivity, hypertension and dyslipidemia, which we have already know, but then we have to focus on these points, which are the emerging and non-traditional risk factor, like preterm delivery, hypertensive disorder in pregnancy, gestational diabetes, autoimmune disease, breast cancer and depression as well. So these are the points which are specific to women, which has to be looked after when we have to see this cardiometabolic disease in women. And now to put forward regarding metabolic syndrome, we see that there are clinical identification of cardiometabolic syndrome based on National Cholesterol Education Program Expert Panel 3, which was published in 2006, revised in 2005, where they say that to diagnose metabolic syndrome, we should have at least 3 or more of all these criteria, like fasting sugar more than 100. This is good for both male and female. Abdominal obesity in men more than 102 centimeter, waist circumference, and women 88. Triglyceride of more than 150. And then when it comes to HDL cholesterol, men less than 40 and women less than 50. mine it is 10 milligram more than men, these women have to be less than 50, and then blood pressure of more than 130 by 85. And if we compare with WHO criteria of metabolic syndrome, you see all other factors are there, but microalbuminuria is specific to WHO criteria which they have given. But these are some of the important factors which we have to look, any 3 of them, or maybe more specific, you can have a clinical identification on your own, but this factor has to be looked after. Regarding pathophysiology in guideline around the world, LDL cholesterol is designed as the primary target of therapy, and just a few lectures before Dr. Supriyo talked about some new factors as well. LDL cholesterol and non-HDL cholesterol is surrogate measure of total atherogenic lipoprotein burden in serum. So HDL cholesterol level have an inverse relationship with risk of CHD in both men and women. The lower the HDL level, the higher the risk, and they are very good predictor as well. So cardiometabolic syndrome represents a cluster of metabolic abnormality that are risk factor for cardiovascular disease. The mechanism responsible for developing this is not very clear, but it is likely to have an insulin resistant theory behind it, which is common feature of cardiometabolic syndrome. Insulin resistance is an important risk factor for type 2 diabetes and can cause vasoconstriction and renal sodium reabsorption, leading to increased blood pressure. Alteration in adipose tissue fatty acid and adipokine metabolism are involved in the pathogenesis of insulin resistance. So excessive rate of fatty acid release into the bloodstream can impair the ability of insulin to stimulate muscle glucose uptake and suppress hepatic glucose production. So non-infectious systemic inflammation associated with adipocytes and adipose tissue macrophages cytokine production can also cause insulin resistance as well. In addition, increased fatty acid delivery, as I told, to the liver can stimulate hepatic very low density lipoprotein triglyceride production, leading to dyslipidemia, which I will discuss little more about it. So regarding pathogenesis and pathophysiology of cardiometabolic syndrome published in that. So the liver secretes large triglyceride rich VLDL that aid at the distribution of oxidizable substrate fatty acid to the systemic tissue. The triglyceride in VLDL are progressively hydrolyzed to lipoprotein lipase to form intermediate density lipoprotein and that LDL particle. The liver LDL receptor clears LDL particle from the circulation. Alternatively, as in the case of insulin resistance, LDL can be taken up into the subendothelial space and they drive atherogenic process in arteries. So plasma triglyceride, which was discussed by Dr. Supriyo sir also, that triglyceride are derived from dietary source, as we know, as well as from de novo synthesis from liver. During this, its path through the digestive system, dietary fat is also lympholyzed, developed into macel, and finally hydrolyzed by pancreatic lipase, thereby enabling the uptake of fatty acid from the small intestine. Upon its entry into the enterocyte, fatty acid will convert it into triglyceride by the enzyme styrl-CoA. This is the pathway which shows that reaction in the setting of insulin resistance and diabetes. The activity of lipoprotein lipase is reduced. VLDL can be incompletely lympholyzed, yielding increased serum level of VLDL remnant and less formation of IDL and LDLs. As VLDL and triglyceride accumulates into the serum, cholesterol ester transfer protein is activated. That is the alternate pathway, and this enzyme catalyzes cholesterol ester from HDL and LDL particles are exchanged for triglyceride out of VLDL and the remnant particle. The HDL particle are catabolized and cleared by the kidney, resulting in lower level of HDL cholesterol, which is again a very important marker. Regarding specific to triglyceride, as we have seen that women have HDL level less than 50 is a risk and had 30% increased risk of cardiovascular mortality. Women with triglyceride less than 200 to 399 have 65% increased risk of cardiovascular mortality, as published in Women's Cardiometabolic Journal. A long-standing association exists between elevated triglyceride and cardiovascular disease. People are more likely to have high triglyceride if they are overweight. they do not exercise and have diabetes, insulin resistance, have increased waist circumference, as we discussed in the risk factor, and that is true for both male and female. Hypothyroidism, lupus, and treatment with corticosteroids also are the cause for high level. So, if you see that emphasis on there are low physical activity, which is very particular to women, we have to encourage them seeing all this high triglyceride pathology regarding women, and we have to teach them if at all there is any risk regarding CVD. So, women are more likely to get high triglyceride if naturally if they are taking birth control pill that includes estrogen, which is another marker. If they are pregnant, pregnancy can temporarily raise the triglyceride level, which is very physiological. Have been through menopause, which is one of the cause of it. Polycystic ovary syndrome, a hormone disorder where they have higher level of male hormone also, and PCOS can also raise the likelihood of heart disease and diabetes, as we know with regarding insulin resistance in this way. The total oral they take oral estrogen or hormone replacement therapy can cause it, and some prescription drug like tamoxifen and raloxifene, which is for malignancy, they also target for estrogen level, so they cause increase in high triglyceride. Women with who had HDL cholesterol less than 50 had a 30% increased risk of cardiovascular mortality. Women with triglyceride between 200 and 399 have 65. Though it looks little, what I have taken from the journal, it looked little exaggerated, 65%, but then there is a high risk when we see if, a triglyceride level higher than that. In a meta-analysis which was again published in the International Journal of Women Health, at 17 population-based prospective study have even shown that there is increased risk in women up to 75%, little exaggerated, which I feel when I got this literature, but for male it is just 30%. So, we think there is a risk factor which is very specific to women and high triglyceride. A little bit regarding menopause. Premenopausal women are relatively protected, as we know, we have learned, against CVD compared to the age-matched male. However, the sex gap narrows after menopause. The long-standing observation led a hypothesis that ovarian steroid hormone and particularly estrogen were cardioprotective, initially supported by a retrospective observational study, but then it got refuted with a few of the slides which I am going to read. However, such conclusions were refuted by randomized control trial of both primary and secondary prevention. The discordance was surprising in light of benefit physiological effect of estrogen on vascular endothelium at the cellular and molecular level, on blood vessel in animal models, and a lipid and insulin resistance biomarkers such as menopausal hormone therapy became one of the most controversial area in women health. The result of major randomized control trial on Human Health Initiative WHI trial and HERT estrogen progesterone replacement therapy study led to a dramatic change in clinical practice in mid-2000, with marked decline in menopause hormone therapy worldwide. Since then, clinicians and scientists have reviewed the RCTs with a critical eye, attempting to explain the discordance with the observational studies. The average Women Health Initiative trial enroll almost age of 63 years women, which are greater than the age of 12 years more than menopausal age, with menopausal hormone therapy in commonly initiated in clinical practice. And they found that when that WHI investigator analyzed the result, the age group between 50 to 59, 60 to 69, and then 70 to 79 year, CAD outcome with the menopausal hormone therapy were found to be more favorable in younger than older women, especially when it was estrogen alone trial. So, consistent with this trend, a meta-analysis of more than 39,000 women enrolled in 23 clinical trials concluded that menopausal hormone therapy reduces risk in women younger than 60 years, but not the older ones. So, debate was going on timing hypothesis, which continues with the recent RCTs focusing on surrogate endpoints such as carotid intima media thickness and carotid artery calcium. So, overall a consensus was emerged that menopausal hormone therapy at the lowest effective dose, remaining an appropriate treatment for menopausal symptoms in early menopause in the absence of contraindications such, but should never be prescribed for the express person of preventing CVD. Now, regarding last recommendations regarding management, the risk factor like diabetes, which I discussed, women with diabetes have threefold excess risk of fatal CAD. And regarding MI, earlier occurrence and higher mortality in diabetic women compared to diabetic male. Regarding heart failure, diabetic women have higher risk of developing heart failure compared to diabetic men. And stroke also, diabetes is stronger risk factor for stroke in women compared to male. So, the recommendation that both women and men with diabetes have aggressive management of their CVD risk factor. Observational studies suggest that women may require greater frequency and intensity of physical activity than men. So, we have to encourage them for physical activity, which is very much lacking in our society as well. And then regarding hypertension, that should also be controlled very well. And it is seen that women who age over more than 60 or are post-menopause, they have a little less control of blood pressure than men. So, we have to get an optimal blood pressure for them with pharmacotherapy and diet and all those lifestyle measures. Now, regarding dyslipidemia, among women, dyslipidemia have higher attributable risk factor at 47.1% when they compare to the other known risk factor of CVD. So, atheroma regression and LDL lowering may be a greater among women on statin than in men. So, maybe it looks but cannot be confirmed unless until we get more data. Statins are recommended very well, are equally effective for secondary prevention in both men and women. However, statin may contribute to a greater likelihood of developing diabetes and myalgia in women, but then we have to look after the other factors. Statins are recommended for primary prevention in women. However, randomized trial has to be still limited in our country. And then obesity is very important factor where in development of coronary artery disease appear to a greater in women than men. And in the Framingham heart study also, obesity increases the risk of coronary artery disease by 64% when they compare to 46% in men. So, it should be women should maintain or lose weight through an appropriate balance of physical activity and diet. Women who need to lose weight should have advice to accumulate a minimum of 60 to 90 minutes of moderate exercise, preferably all day of the week. That should be encouraged to do more exercise what we have learned till date. So, physical inactivity is another very important factor, especially for women. So, prevalence of inactivity and sedentary behavior is higher among women than men, and it is a kind of taboo or traditional way of living that they don't get encouraged in physical activity, outside movement and exercise. They have less opportunity for them. So, overwhelming evidence are there that physical activity is one of the most powerful and health promoting factor that clinician can recommend to those women. Women should be advised to accumulate at least 150 minutes per week or even more moderate exercise, 75 minutes per week for vigorous exercise or equivalent combinations. And smoking though less, but still it's upcoming, and it was old factor, but again it's upcoming, and we have to prevent them seeing all those risk factors regarding cardiovascular disease. So, to summarize my talk, cardiometabolic disease remain the leading cause of death in women. It is imperative to understand the mechanism that contribute to worsening risk factor profile in young women in order to reduce future cardiovascular mortality and morbidity, and increase recognition of the prevalence of traditional cardiovascular risk factor and their different impact in women, as well as emerging non-traditional risk factor which I showed are unique to the women and are more common, contribute to new understanding of mechanism leading to these worsening outcome for women. Thank you very much.
Thank you, Dr. Subhash, for a very profound lecture. One point of difference: women are as active as men, perhaps more. I'm sorry to say.
Mentally or physically, ma'am?
physically as well.
Okay, accepted.
I am a working
Accepted.
woman.
Accepted.
I work at
Jokes
home.
apart.
I work at my working place as well. Another thing.
So you are a role model, definitely, I can say.
I'm not a role model, but that sentence.
Works at home
Yeah, so
and sees all throughout day in the office. So probably she is doing more activity than me. So I also accept it. That women are more active than men.
I mean physical activity, sir.
Sir,
Not
we are
activity.
talking- sir, when you talk of today's era, we will talk more about mental activity. Physical activity is
Yeah.
as such there. So if you remember our grandmothers or even our mothers, I guess they worked harder than us.
Very
There
true.
was no washing machine at home. There
Very
was no
true.
mixie at home. There was no working washerwoman at home. Everything was done by our mothers. And I don't know, but I think they led a healthier life than us. I guess.
Definitely.
True, that is a comment from me. The more, less you eat, rather, more you live, and more you work, more you live. That is the most probably the first you have to eat less, work more. Then you have to work more to live more.
Very true. Okay, I think it's done. Thank you.